Yeah, meeting देखा ना बोला start ना show.
ఇది అట్లా అన్నట్టుంది. నానా ఒకసారి ఇక్కడ రా.
Hello, hello. Welcome back, everyone. And I hope every one of you is doing good. I'm sorry for the delay. I get something to do. Okay. All right. So we're going to start. Is my voice clear to you guys today? Is my internet good today?
Yes,
Yes,
sir.
sir.
Okay. All right. Okay. So we're going to start from where we left. And I think we completed till fetal circulation and the embryology. So today we are going to do the cardiac anatomy, then we start the cardiac physiology today. Okay, anybody have any question, any confusion from yesterday's lecture? Anybody have any question, any confusion? Yep, everything good? Any confusion? Or should I ask a questions from yesterday lecture? Everybody's good? Mm-hmm.
Yes, sir.
Yes, sir.
Everything good? Okay, let's see. Okay, so we're going to discuss now the heart anatomy. So, in order to understand the heart anatomy, you should first understand the position of heart. What is the location of the heart being there? Okay, let me create the whiteboards. Okay, give me a minute, please. Give me a minute. I will be back. Okay. All right, so sorry. All right, so heart anatomy, we're going to discuss the heart anatomy. So in the heart anatomy, you should know the surfaces of the heart. So what chamber makes the anterior surface, posterior surface, medial surface, and the inferior surface? Heart anatomy. Okay. So very important to know the anterior surface. Anterior surface of the heart. Can anybody tell me what chamber forms the anterior surface of the heart? What chamber? If you look at this,
Right ventricle.
right ventricle, excellent. Right ventricle is actually there, which is located very anteriorly. Right ventricles, it forms the anterior surface. Okay. Anterior surface is actually formed by your right ventricle. Okay. And why it is very important to understand that anterior surface is formed by right ventricle, because any kind of chest trauma, if you get the blunt chest trauma or penetrating chest trauma, that is anterior chest wall trauma, will always injure your right ventricle. So right ventricle is most commonly injured chamber in case of the chest wall trauma. Okay, so that's why it's very important to understand. And opposite to the right ventricle, opposite to right ventricle, there will be the posterior surface of the heart. So, what chamber forms the posterior surface of the heart? The chamber which forms the posterior surface, it will be called left atrium. Left,
Left atrium.
left atrium is a posterior chamber. Suppose this is I say this is my chest wall. This is my chest wall, which I'm drawing the picture for you guys. This is my chest wall. Chest wall. And this is how the heart looks like. So this will be my heart, which I'm drawing with the red color. This will be my heart. So it looks like this. This will be my heart. Okay, this is my heart. And this will be your, okay, this will be your atrial, this will be your atrioventricular canal. This will look like this, atrioventricular canal. And this will be my septums, atrial septal, atrial septum, ventricular septum. Okay, so these are my septa. These are my septas being there. Okay, so this is my chest wall being there. So look at this. This is my chest wall. This is my anterior surface. Chest wall is actually there, and here I will have what, the posterior wall being there. So posterior wall is actually indicated by vertebral bones. These are my vertebral bones. Okay, these are my vertebral bones. Okay, this is my posterior surface. So look at this, these are my vertebrae. So whenever you get the MRI or the X-ray, whenever you get the MRI or the X-ray, how will you identify this posterior surface or anterior surface? You have to look at your vertebrae. If the structures which are close to vertebrae, they will be posterior structures, and the structures which are close to the ribs, they will be called anterior. They will be called anterior structures. Okay, so these are my vertebrae being there. So this will be my right atrium. This will be my left atrium. This will be my left ventricle. And this will be my right ventricle. So if you look at this, right ventricle is actually most anterior surface. This is actually right ventricle. Now, opposite to right ventricle is called your left atrium. Left atrium is making the posterior surface. And why? Because it is very close to my picture in the vertebrae. It's very close to the vertebrae in my picture. So why posterior surface is very important? Because posterior surface is actually related closely to very important structure in the thorax. Very important structures are passing very nearby to your left atrium. Okay, so they are passing nearby to the left atrium. So what structure is actually passing near to the left atrium? There's a one structure which is called foot pipe, that's called esophagus, which I am drawing with the blue color. So esophagus is actually passing very near to your left atrium, because esophagus will be more posterior structure. So once I get the enlargement of left atrium, once I get enlargement of left atrium, it will do what? It will compress my esophagus. Is it? So my esophagus is going to be compressed if I get the enlargement of left atrium. Okay, so that one structure can be compressed in the enlargement of left atrium. Now there's a one nerve which also passes very close to the left atrium, that is called recurrent laryngeal nerve. and that will be your left recurrent laryngeal nerve or right recurrent laryngeal nerve. This nerve is actually passing, and it makes a loop around that. This is called recurrent laryngeal nerve. So can anybody tell me this is what? Left recurrent laryngeal nerve or right recurrent laryngeal nerve?
Left recurrent laryngeal.
The left one.
Very good. Left one because it's very close, because left atrium is close to the left recurrent laryngeal nerve. So these two structures are closely related to the left atrium. So the disease which causes left atrial enlargement will actually compress these structures. So what is the name of the disease in which I will get left atrial enlargement? Well,
Partners.
Myelofibrosis.
very good. Mitral stenosis. Could you please tell me another disease which can also lead to left atrial enlargement? One is mitral stenosis, and what's the other disease which can cause left atrial enlargement? That will be called hypertrophic cardiomyopathy. When you get left ventricular hypertrophic cardiomyopathy, is it? Okay. So once you get left atrial enlargement, it can compress these structures. So if it compresses your left recurrent laryngeal nerve, I will get what? Hoarseness. Is it? Hoarseness of my voice. Hoarseness of voice. And if it compresses your esophagus, what will I get? If my esophagus compression is there, what I will get? I will get dysphagia. Okay. So dysphagia, hoarseness, left atrial enlargement make a one syndrome that's called Ortner syndrome. So what is Ortner syndrome? Ortner syndrome is enlargement of left atrium which causes hoarseness and the dysphagia, and I told you why. So this is the reason the left atrium is very important to understand. So posterior structure is actually formed by left atrium. Okay, so that was anterior and the posterior surface. Now coming to the apical surface, the apex is actually formed by the left ventricle, or I will say the lateral surface is formed by the left ventricle. Lateral surface is formed by left ventricle, and medial surface is actually formed by the right atrium. Right atrium form the medial surface of the heart. Okay, now coming to the inferior surface. So look at this. This will be my inferior surface. So inferior surface is actually formed by both. Inferior surface is actually formed by your right ventricle and the left ventricle both. You can look at this. This is my inferior surface. Okay. Inferior surface is actually formed by both. So 1/3 it is by the right ventricle and the 2/3 is by the left ventricle. They form the inferior surface. And can anybody tell me what is the other name of the inferior surface of the heart? Yep. What is the
Anterior.
other surface?
Diaphragmatic,
Very good. Why?
because it is in contact, like the diaphragm is below
Very
that
good,
surface.
very good. It's actually closely related to the diaphragmatic surface, because below the inferior surface of the heart, diaphragm is sitting. It is in the direct contact with the diaphragm, so that's why it's called the diaphragmatic surface of the heart. Very good. Okay, so these were the borders of the heart and heart anatomy. Very important to understand. And anybody have any question regarding this heart anatomy? Then I will jump to the pericardium, which is a covering of the heart. Is it? All right. Now let's discuss the pericardium. Pericardium. So pericardium is actually the outer covering of the heart is called pericardium. Is outer covering of the heart is called pericardium. Okay. So pericardium is actually derived from what? Pericardium is actually derivative of what? Mesoderm, endoderm, or ectoderm. It's actually mesoderm derivative. Okay. Mesoderm derivative. Now, pericardium is actually composed of three layers. It's actually composed of three layers. So there are three layers of the pericardium from outer to inner. If you go from outside to inside, it's composed of the three layers. So first layer of the pericardium will be what? It will be called fibrous pericardium. Outermost layer of the pericardium is called fibrous pericardium. Fibrous pericardium. And the second layer will be called what? Parietal pericardium. Parietal pericardium. And the layer which is in the direct contact with the myocardium, which is in the direct contact with your heart, is called your visceral pericardium. Visceral pericardium. Okay, so between the visceral pericardium and the parietal pericardium, there's a space that is called pericardial space. So pericardial space is what? Is a space between your visceral and the parietal pericardium, and that space contain a small amount of fluid which act as a lubricant, or which actually reduces the friction, in the heart. So that's called pericardial space. So pericardial space contain a small amount of the fluid. Okay, pericardial space. So can anybody tell me what are the functions of the pericardium? Yep.
Protect the heart.
Decrease the friction
Excellent.
between
Very
the
good job. Excellent. Very good. Contains pericardial fluid. Very good. Decrease the fraction and protects the heart. Very good. Protects the heart. That's very, very important to understand. Very good. So these are the functions of the pericardium. All right. So now the coronary artery and the coronary vein or coronary sinus, they actually enter the heart through pericardium. First, they enter the heart through pericardium. So these coronary blood vessels, coronary artery and the coronary vein, sorry, they are present in what layer of the pericardium? Visceral, parietal, or fibrous? Can anybody tell me the answer? What is the location of coronary artery within the pericardial layer? They are present within the visceral pericardium. Okay. So coronary artery is present within the visceral pericardium. Visceral pericardium. Okay. All right. So that's actually your pericardium. And now other important thing of the pericardium is what? The pericardium nerve supply. The nerve supply of pericardium is through the pharynx nerve. So pharynx nerve supply your parietal pericardium and the fibrous pericardium. And the visceral will not have this supply because this is a sensory nerve. Visceral will have what? Autonomic nerve supply. So pharynx nerve supply your parietal and the fibrous pericardium. And why it is very important to understand the pericardium supply? Because once you get the inflammation of pericardium, that's called pericarditis, it will lead to the irritation of the pharynx nerve. So once the pharynx nerve is irritated, you will get the referred pain. And the referred pain will be towards what? It will be your shoulder joint. It will lead to shoulder pain. Okay. So you might get the shoulder referred pain because pharynx nerve contain the same dermatomes which supply your shoulder. All right. So that would be your there. So this referred pain will be going to where? It will be going to the left shoulder, right shoulder, or both shoulders. Yep.
Left.
Yeah, most often.
both shoulder, but most
Especially left,
often
but
the
in
left.
that can go both.
Yeah. So mostly it goes to the left shoulder, but it can also go. It can also be referred to the both shoulders. Okay, so that was pericardium. Now, very important stuff is actually coronary blood supply. Coronary blood supply. Coronary blood supply. So coronary blood supply is very important to understand, is it? So coronary blood supply is very important to understand. It's very easy. It's very easy. Just keep focus. Be focused here. So this is actually your, suppose this was my aorta. This is my ascending aorta going up. So this is my ascending aorta. Ascending aorta going up. Now ascending aorta, this is my left side and this is my right side. So ascending aorta will give two branches. It will give left coronary artery and the right coronary artery. So it's going to give rise to left side, it will give left coronary artery. So this is my left coronary artery. Okay. So left coronary artery is going down. This will be my left coronary artery. Okay. Left coronary artery. Okay, so left coronary artery is there. Now left coronary artery is going to divide into the two branches. It's going to, so left coronary artery will supply the left side of the heart. So what is the role of left coronary artery? The role of left coronary artery is to supply the left side of the heart. Supply the left side of the heart. Okay, that's a purpose of the, or that's a function of left coronary artery. Supply the left side of the heart. So in the left side of the heart, we have the left atrium being present and the left ventricle being present. So left coronary artery will supply both these chambers. Okay, so how it is going to supply? So left, suppose this is my left side of the heart being there. This is my heart. Blue structure is called heart. Okay, so this is my left side of the heart. This is my left side of the heart. Okay, and this one is my actually your septum AV canal being there. This is my AV canal being there. So when left coronary artery comes down, it actually give rise to the two branches. When it reaches to the atrioventricular canal, it gives rise to the two branches. And what are these two branches? It is going to give rise. It's going to give rise to your left anterior descending artery and the left circumflex artery. So it gives rise to what? This is one branch which is running anteriorly on the surface of your left ventricle. So this is called left anterior descending artery. So it gives rise to the left anterior descending artery. This is one branch, LAD, and other branch, it is continued on the lateral border. On the lateral border, it is continued at your left circumflex artery. So this will be my left circumflex artery. So left coronary artery divided into two branches. This is my left anterior descending artery, LAD, and this will be my left circumflex artery, LCX, which is actually making a U-turn, and going to the lateral surface of the heart. So for now, just focus on the left anterior descending artery. So LAD, I'm going to discuss the areas of left ventricle supplied by left anterior descending artery. So LAD supply. So left anterior descending artery, as a name suggests, it's called anterior artery. So remember, it will supply those structures which are present anteriorly in the left ventricle. So it will supply all the structures which are present anteriorly in the left ventricle. That is why it is called anterior descending artery. Supply anterior structures, anterior structures of left ventricle. Okay, so left ventricular blood supply should be on your tips. It should be on your tips. So first, the artery which supply the anterior structure of left ventricle is called LAD. So what are the areas which are present in the anterior surface? So can I say it will supply the anterior surface of left ventricle? So LAD supplies what? Anterior surface of left ventricle. Okay, it supply anterior surface of left ventricle, and it is also going to supply what? Anterior two-third of interventricular septum. This is my interventricular septum being there. So it will supply anterior two-third of interventricular septum. Okay, anterior two-third of interventricular septum. Everything anteriorly will be supplied by LAD. So anterior two-third of interventricular septum will be supplied by LAD. Now the third structure which is supplied by the LAD is what? You know what other structure is present anteriorly in the left ventricle will be your papillary muscles. So this papillary muscles will be what? Anterolateral papillary muscles, because papillary muscles are component of mitral valves, is it? Anterolateral papillary muscles. Okay, anterolateral papillary muscles are going to be supplied by your LAD. So this is a supply of LAD. LAD supplies your anterior surface. It's running anteriorly, so it will supply everything which is present anteriorly in the left ventricle. Okay, so we supply the anterior surface of the left ventricle. Now let's discuss the posterior surface. So anterior supply is being supplied. Now we are going to discuss the posterior surface of left ventricle. Posterior surface of left ventricle. So there's a one artery which is completely opposite to your left anterior descending artery. And the name of that artery is called posterior descending artery. Simple as that. Posterior, and the artery of the posterior surface of left ventricle is called what? Posterior descending artery. Posterior descending artery. It's called posterior descending. It's called PDA. So it will take the charge. It will take the charge of posterior surface of left ventricle. It's running completely opposite to the left anterior descending artery. So whatever structures are present on the posterior surface of left ventricle will be supplied by PDA. So what is the supply of the PDA? PDA supply the posterior surface of left ventricle. Simple as that. It supply posterior surface, posterior surface, posterior surface, and it will supply what other structure? It will supply the posterior 1/3 of interventricular septum. So it will supply what? Posterior 1/3 of the interventricular septum will be supplied. Okay. So it supplies what? Anterior 2/3 is supplied by LAD. Posterior 1/3 will be supplied by your PDA. Okay. So PDA supply what? Posterior 1/3 of interventricular septum. 1/3 of interventricular septum. Okay. And what is the third structure will be supplied by the posterior descending artery? It will be also posterior, and this will be posterior medial papillary muscles. Is it? Completely opposite. So if you want to understand the PDA, first you should understand LAD. What are the areas supplied by LAD? And just make it opposite. Just make it other way. Make it other way, so you will get it very easy. So this will be a posterior medial papillary muscles. Papillary muscles. Okay, so these are the areas supplied by the PDA. Now you guys must be thinking, PDA is a branch of what artery? So PDA, on the basis of the PDA origin, the circulation in the heart is classified into two types: right dominant circulation, left dominant circulation, and the co-dominant circulation. So we have the three types of the circulation within the heart depending on the origin of the PDA. So if your PDA comes out of your right coronary artery, if the right coronary artery give rise to the PDA, the circulation will be what? It will be called right dominant. And do you know, 80% of the time, the PDA comes out of right coronary artery. So this is called right dominant circulation. Is it? Right dominant circulation. Okay. It's almost 80% of the time. 80% of the time it comes out of this. Okay. If the PDA is coming from right coronary artery. Now, if the PDA is coming from the left circumflex artery, if left circumflex artery give rise to the PDA, the circulation will be called what? Left dominant circulation, which happens in 10% of the time. 10% of the time. So in 10% of the time, the PDA will come from where? PDA will come from the left circumflex artery. It's actually 10%. Okay. So 10% is actually your PDA coming out of this left circumflex. Now, similarly, PDA can be coming out of both arteries. Your RCA, right coronary artery, plus left circumflex artery, both contributes to the PDA. And when they both contributes to the PDA, the circulation is called codominant. Codominant means both together at the same time. So that will be called codominant circulation. And that happens in how much time? It actually 10% of the time. Okay. So that's called the circulation of the, all right, PDA. Right dominant, left dominant, and the codominant one. All right. So this is actually the PDA and its supply. Now we have another artery which was going on the lateral surface of the heart, LCX.
Excuse me,
Yep.
sir.
Uh-huh.
Sir, Sir, if this circulation gets changed, like we say 10%, it will be different 10%. Is this later on making any difference in the patient, like the person sign symptom or anything later on in the life?
No, there will be no difference. There will be no difference. There will be
Like
no
the
difference.
same, like
No.
the normal supply will,
Yeah,
but just
everything.
the vessels are different, but they're getting the same blood supply, like anything affect
Yeah.
the cardiac
The
output
PDA,
or something.
yeah, PDA will receive the same amount of the blood from every vessel. Either it
Okay,
is
thank you.
LCX, if PDA is supposed to receive 10% of the blood, it will always receive 10%. And it doesn't depend upon from what artery it is coming. Okay? It doesn't
Okay.
depend. Okay? There's no evidence about this. Okay? All right, so that will be your PDA. Now we have another artery that's called LCX, lateral left circumflex artery, and left. So I supplied. So look at this. I supplied the anterior surface of left ventricle, posterior surface of left ventricle. Now two surfaces are other remaining. They are called lateral surface and your inferior surface. So artery which supply the lateral surface of left ventricle is called LCX, lateral surface. Simple, lateral surface. So lateral surface is very simple. So you see lateral surface of left ventricle is supplied by your left circumflex artery. Now coming to the inferior surface. So what arteries supply the inferior surface of left ventricle? Anyone?
Sir, I have a question.
Yeah, sure.
S- So, obtuse marginal artery is a branch of LCX, or it's a branch of the left coronary artery, or it's a bifurcation of the left coronary artery?
Good question. Good question. Obtuse marginal is a branch. I was about to come at the end of the obtuse. Okay. So, but you asked it, you asked me here. So let me clear it. So, obtuse marginal is what? Obtuse marginal is running on the margins of left ventricle. Is running on the margins of left ventricle, and it is a branch of your left circumflex artery. Left circumflex artery, when it reaches to the distal ends of the left ventricular surface, it will give rise to the obtuse marginal artery. Okay, so it's a branch
Thanks.
of LCS. Good question. Very good. Okay, it's an artery which blocks most often, is it? But once the obtuse marginal drop, the collaterals will develop, and the collaterals will develop. Patient will not get the symptoms. Okay, so LCX is actually there. LCX supply the lateral surface. Now coming to the inferior surface. So I discussed anterior surface of left ventricle, posterior surface, lateral surface. Now inferior surface. What is the name of the artery which supply the inferior surface of left ventricle? Very important to understand that. There's one artery which supply the inferior surface of left ventricle, that's called right coronary artery. Right coronary artery supply the inferior surface of the left ventricle. Very, very important to understand. This artery is very important to know. Right coronary artery. Now, once you get blockage of the right coronary artery, the ECG leads will show ST elevation. So, in what leads I will get ST elevation if my inferior MI is suspected? That will be called lead 2, 3 AVF, limb leads. Limb leads are going to show me the ST elevations if RC is blocked. Okay, so I supply my entire left ventricle. So left ventricular blood supply should be on your trips. So just again, brief review. Anterior surface of left ventricle supplied by your left anterior descending artery. Posterior surface of left ventricle is supplied by posterior descending artery. Lateral surface is supplied by your left circumflex artery, and the inferior surface of left ventricle is supplied by right coronary artery. Okay, so that's actually the, I would say, the conclusion of this blood supply. Okay, all right. Any question? Anybody have any confusions? Then I will jump to the right coronary and the right side supply. Right coronary is very simple to supply. Is it? So left ventricular supply should be on your trips, because in the pathology I will discuss the leads. I will discuss the leads where you will see ST elevations. Okay. So now let's discuss the right coronary artery supply. RCA, right coronary artery. Right coronary artery. So right coronary artery is going to supply the blood to what? Right coronary artery. Okay. So right coronary artery is artery of the right side, but it also supply the left ventricle. But its role is what? Its role is to supply the right side of the heart. So it supplies your right atrium, right atrium. It supply your right ventricle, and it supply your SA in the AV node, because they are the structure which are located in the right side of the heart, AV node and SA node. Okay, AV node and the SA node. Okay, so these will be the supply. These are the structure which are supplied by your right coronary artery. Now, right coronary artery, once it reaches to the margins of right ventricle, it gives rise to the branch that's called marginal artery. Right marginal arteries will be the branches. So marginal arteries can be coming from any artery. Even LAD can give rise to marginal arteries. Your left circumflex artery can give rise to the marginal arteries, and right coronary artery can also give rise to the marginal arteries. So right, so these are the supplies of your right coronary artery. And once your right coronary artery get blocked, when there's a blockage of right coronary artery, the patient will have what symptoms? Patient will have the bradycardia, reduced heart rate, because it will lead to ischemia of the SA node, or you will get what? Severe hypotension, reduced blood pressure will be seen. Okay, reduced blood pressure will be seen because right ventricle contraction will be affected. So reduce blood pressure. Okay. So that's all about your right coronary artery. All right. So, and the branch of right coronary artery, which supply blood to the right ventricle is called right marginal artery. Right. Why? Because at the distal ends, it will be converted into marginal arteries. So that's all about the blood supply of the heart. Okay. Now, what is the name of the vein? What's the name of the venous drainage of the heart? What is the name of the vein which drains the blood out of the heart? Anyone knows the answer? Vein. Vein of the blood. Venous drainage.
Is that coronary sinus?
Excellent. Coronary sinus. So coronary sinus is a vein which drains the blood out of the heart. And this vein contains most of the deoxygenated blood of the body. So deoxygenated blood, most of the deoxygenated blood in the body is present in the coronary sinus. And could you please tell me what is the embryologic derivative of coronary sinus? Do you know? I discussed the heart too.
Left sinus venosus.
Excellent. Good job. Very good. Appreciate it, Rahul. Good job. Left horn of the sinus or left side of the sinus venosus will be giving rise to your coronary sinus. Okay. And this coronary sinus is actually running in what? It's running in the AV groups, atrioventricular groove, and it drains into your right atrium. Okay. So it's running in the left atrioventricular groove. All right. Anybody have any questions? So that was all about the heart anatomy, and we will jump to the physiology of the heart now. Did you guys understand? Anybody have any question?
Sir, I have a quick question, sir.
Yep, sure.
Uh, can we determine if a patient has right dominant circulation or left dominant circulation by just looking at an ECG, sir?
No.
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 Why, sir?
How will you tell me on the basis of ECG that this patient has the right dominant circulation? I cannot tell because it's all about PDA. You know, in the ECG, there's no any lead in the standard ECG. I am talking about standard ECG. In the standard ECG is 12 leads ECG. So in those 12 leads, no any lead indicates the posterior descending artery. Is it? So we have the V1 to V6 leads are there, which doesn't show the area supplied by the PDA. But in the 15 leads ECG means you increase two more leads, V7 to V9. That shows us the PDA being there. That will only show us the ECG shows us what? ECG shows us the ischemic changes in the myocardium. ECG will not show us from where the PDA is coming. It will just show us the ST elevations in the area supplied by the PDA, but it will not show us from where it is coming. So to actually look at these branches, to actually look at for the right dominant circulation, left dominant circulation, you have to do the angiography. You have to do the angiography of the coronary arteries. But ECG, even echocardiography cannot tell you the right dominant or left dominant. Okay, ECG just shows us the ischemic changes in the heart. It cannot show us from where this branch is coming. You have to do the coronary angiography for that, and that's not important one, is it? I don't know why you guys are more focused. You should have actually asked me a question that when the PDA is blocked, where I will get the ST elevations. When the PDA is blocked, what will be the patient presentation? When the left anterior descending artery is blocked, what will be the patient presentation? So just try to focus on the high yield stubs. What are the high yield stubs being there? All right. So ECG will not show us. That's my answer. Okay.
No, sir. My actual doubt is, if suppose a patient has an MI, most of the changes in the ECG regarding the left ventricle, sir. So, if the ECG shows the left ventricle is normal, but the right ventricle has an MI, then what will be the affected artery and what is the predominant circulation? That is my actual question, sir.
Yeah, ECG shows you the ECG. First thing is that ECG is a recording of the left side of the heart.
Yes, sir.
It's a recording on the left side. It's not a right side recording. Okay. Right side, for the right side, we have the JVP being there. Okay. All right. So ECG shows that about the left. ECG can show you the blockage of the left anterior descending artery. Means when you get the anterior, so if you have the anterior surface of left ventricle getting infarction, it means LAD is blocked. It's being LAD is blocked. I know what is your question. If the ECG shows, if ECG shows the blockage of left circumflex artery, if ECG shows blockage of left circumflex artery, and you are suspecting, so it means lateral wall of the left ventricle will be getting infarction. Now your question is that, is there possibility that the posterior surface of left ventricle will be getting infarction or not?
Yes, sir.
We cannot say like this. We cannot say like this on the basis of LCS infarct, because ECG does not tell us the location where the left circumflex artery is exactly blocked. Your left circumflex artery can be blocked distally before giving the branch. So it might be blocked distally. It might be blocked distally before giving the PDA branch. Okay, so ECG will not show us the exact location of LCX blocked. So that is why on the basis of ECG, I cannot say that if LCX is blocked, it means my posterior surface will also be blocked. I cannot say this.
So
Okay.
that's why CT angiography is done.
CT angiography is going to tell you everything. CT angiography will at least tell you, or coronary angiography will show you everything, because you are doing the imaging, it is actually ultrasound guided. It will show you the arteries, where the arteries are coming. Is it? Once you actually pass the needle into radial artery or femoral artery, it will actually show you. So femoral vein or femoral artery, it will show you from where the arteries are coming. That's the reason we do the coronary angiography. Is it?
Okay, sir. Thank you, sir.
ECG will only tell us the blockage. It will not tell us the side of the blockage. And the side of blockage will be seen with the angiography. Okay?
Okay, sir.
All right.
Thank you, sir.
No worries. Anybody have any question?
Hello, Doc.
All good?
Hi, Doc. I have a suggestion.
Yeah.
I'd recommend good afternoon, everyone, to write our questions down in the course of the lectures, especially if it is not an urgent related to what we are doing. Remember, we have a crash course doing that, and time is very of the essence. So I think it will save us more time, and we'll get to meet our daily target if people can write their questions down and wait till the end of the classes. Just a suggestion.
Oh, yeah. Good suggestion. We will actually, okay, I will take the feedback from every student, and so we'll take the voting. We'll do the voting system. And if the students say that we want to ask the question at the end of the lecture, and I will go with that. Okay. So I have to take the opinion from every student. All right. Okay. So we will consider your suggestions. Thank you so much for your feedback. I really appreciate that. Okay. All right. So, okay. Now we're going to discuss the physiology. So before jumping into the physiology, we're going to do what? We are going to do the cardiac outputs. So cardiac output and its variables. So first, let's discuss the what is actually cardiac output. Cardiac output. So cardiac output is the amount of blood which is pumped by the left ventricle with each cardiac cycle. The amount of blood which is pumped by left ventricle with each cardiac cycle is called cardiac output. So cardiac output equation is what? Equation of the cardiac output is what? Cardiac output will be equals to your heart rate times stroke volume. Heart rate times stroke volume is called the cardiac output. So we will be discussing the variables of the cardiac output. What are the variables which actually affect your cardiac output? So first variable which we are going to discuss is stroke volume. Stroke volume. Stroke volume is again what? It's the amount of blood which is going out of the left ventricle, either in the forward direction or backward direction, we don't consider. So blood which is coming out of the left ventricle is called the stroke volume, okay? Or the volume of blood coming out of the left ventricle is called stroke volume, okay? So what are the factors which can increase my stroke volume? What are the factors which can increase my stroke volume? So the factor number one will be what? When you increase the preload in the heart. Preload. So preload means the venous return. If you give more blood to the heart is very loyal. Heart is very loyal. It will actually return you that much amount back. Okay. So increase preload being there. So can anybody tell me what is a normal physiological state where your preload increases?
Pregnancy.
Pregnancy.
Pregnancy,
Very
blood
good.
volume increases.
Early pregnancy or late pregnancy?
Mid of the pregnancy.
No, early pregnancy. Do not say mid. Okay.
Oh.
It's early
After
pregnancy
Yeah,
because
sorry, early pregnancy.
early pregnancy should be there because that's the adoption being there. So you want to increase the blood flow to your fetus. Okay. So mother have to increase its blood volume, and when she increase her blood volume, the blood will also go to the heart, and that will increase the preload. Very good. So early pregnancy is there. What is the other physiological state which can increase the preload to the heart? Anyone? Can I say exercise?
Exercise, anxiety, panic attack.
No, anxiety. Where are you going? Where are you going? Do not say anxiety. Okay. So it's exercise. Can anybody tell me how exercise increase the preload or venous return to the right side of the heart? Uh-huh. It's going to do what?
Vasoconstriction.
Venoconstruction. Excellent. Venoconstruction will be there. Okay. Venoconstruction will be there. Okay. All right. So that will be your exercise. That will increase the preload. So one parameter which increase stroke volume is preload, increase preload. Another parameter which will actually increase your stroke volume will be your increased heart contractility. When you increase the contractility of the heart. Okay. So increased contractility being there. So how will you increase the contractility of the myocardium? Contractility, when you increase the contractility, it means the more blood will be coming out of the heart. So how will we increase the contractility of the heart? So what are the physiologies which will increase the contractility will be your exercise. Can anybody tell me how exercise increases the contractility? What's the mechanism? Yep. Exercise.
Sympathetic stimulation.
Very good. Excellent. Sympathetic, increase sympathetic nervous system stimulation. And once you increase the sympathetic nervous system stimulation means more beta 1 stimulation. Is it? Beta 1 stimulation on the heart. So increase beta 1 stimulation. Okay. And that's actually the reason. Okay. Another thing is actually anxiety. Why anxiety? Because anxiety will activate your sympathetic nervous system. So you get the contractility being high. Okay. Now, third parameter, which will increase our stroke volume, will be what? It will reduce afterload. Reduce afterload. Now, what is afterload? Afterload is a pressure against which the left ventricle is contracting. It's simply a pressure in your aorta. Blood pressure in your aorta is called your afterload. So once I reduce the afterload, it will be very easier for left ventricle to remove the blood out of it. Okay. So that will be your afterload. I reduce the afterload. And can anybody tell me what is a normal physiological state in which the afterload reduces. Yep. Mm-hmm. Mm-hmm. That will be exercise again. Is it? Exercise. Can anybody tell me how exercise reduces the afterload? What's the mechanism? Mechanism is very important, otherwise you will forget it. So when you are exercising, what will happen to the oxygen level at the muscle? Oxygen level at the muscle will decrease or increase? Yep.
Decrease.
Excellent.
It de-
O2 decreases. And you guys know that O2 decreases in muscle. And whenever your O2 decreases in the muscle, it will do what? It will do what? Hypoxia in every tissue will cause vasodilation except pulmonary
lung.
lungs. So you get what? Vasodilation here. All right, so that will be our presentation of the afterload. Afterload reduces, so that will lead to your, okay? Did you guys understand this? How afterload is reduced? Exercise reduces your afterload, okay? Now we're going to discuss the myocardial oxygen demand. So before going to myocardial oxygen demand, I would love to discuss the contractility, okay? Contractility, contractility. Can anybody define contractility for me? What is contractility? What's contractility? Yep. Contraction of the cardiac muscle is called contractility. It's very simple. Why you guys keep thinking more? Okay. So contraction of cardiac muscle is called contractility, and it's being increased by increased beta 1 stimulation. When you have the more beta 1 stimulation, it will lead to what? Increased contraction. Now, question is that how it goes? What's the mechanism? So when you have the increased beta 1 stimulation, it will increase what? It will increase cyclic AMP inside the heart. Is it? And when you have the increased cyclic AMP inside the heart, what is going to happen when you have the increased cyclic AMP inside the heart? It will activate the one protein that's called protein kinase A. And this protein kinase A will do what? It will lead to the phosphorylation of the phospholamban. So it will lead to phosphorylation of phospholamban, which actually regulates the calcium level within the cytoplasm. Phosphorylation. You guys know that kinase, what's the role of kinase enzyme? It causes phosphorylation. So phosphorylation of phospholamban will be there. And once I get the phosphorylation of phospholamban, it will lead to increased calcium. Increased calcium in the cytoplasm. And when you have the increased calcium, the muscle will contract. Okay. So this is how. So if you want to increase the contractility, just increase the intracellular calcium levels within the cardiac muscles. Okay. So beta 1 stimulation increase in this way. And what are the other factors which will increase the calcium within the cardiac cells? Do you know what are the other factors which will increase the calcium inside the cardiac cells, and that will increase the contractility? Okay. So the medication called digoxin, is it? Digoxin will also increase your contractility by increasing your calcium within the cell. Now, what are the factors which will reduce the contractility of myocardium? Anyone who wants to voluntarily tell me?
Beta blocker.
Beta blocker, excellent, very good. What else?
Calcium channel blocker.
Excellent, good job, very good. CCBs, very good. And can I say change in the pH, decrease pH, acidosis? Because for the
Yes, acidosis. Yes.
yes, exactly. Acidosis, because for the normal functioning, you need a normal pH, is it? And obviously, heart failure. Simple as heart failure, okay? So these are the parameters which will actually reduce your. All right. So that's all about your contractility of the heart. Now, factors on which the myocardial oxygen demand. So what are the factors which will increase the myocardial oxygen demand? Myocardial oxygen demand. Oxygen demand. Yes. Factors which will agree myocardial oxygen demand being there. So factors like when you have the increased contractility, the heart will consume more oxygen, is it? Yep. What else? What else can actually increase myocardial oxygen?
Afterload.
Increase afterload. Very good. When you are putting more pressure on the left ventricle, they will consume more oxygen. Very good.
Yes, when you increase the heart rate.
Excellent. Increase heart rate. And what's the fourth parameter on which the myocardial oxygen demand increase? This is very important to understand because
Ischemia.
not ischemia.
Hypertrophy.
Hypertrophy.
Hypertrophy, very good. Hypertrophy, very good. Hypertrophy, very good. Or when you increase the preload to the heart, when you increase the preload to the heart, hypertrophy can be there. Very good. Hypertrophy is there when you increase the diameter of left ventricle. Excellent. So these are the factors on which the myocardial oxygen demand increases. Now, there are some diseases in which you have to reduce the myocardial oxygen demand. And how will you reduce the myocardial oxygen demand? By reducing contractility, reducing afterload, reducing heart rate, or reducing the preload to the myocardium. And the diseases like angina, myocardial ischemia, or myocardial infarction, you have to reduce the oxygen supply to the heart. Okay, so that's the reason I'm discussing the oxygen demand of the heart. All right, now you guys know equations of stroke volume. What is the equation of stroke volume? Stroke volume will be equals to your end diastolic volume minus end systolic volume. So I will discuss these things tomorrow in the detail. Tomorrow I will discuss these things and the pressure volume loops and the Frank Starling. So tomorrow we will discuss the very important topics. Okay. Anybody have any question? Any question anybody have? Any question? No? All right. Okay. So
Hello, Doc. What time tomorrow are we meeting?
Same time. I'm sorry for delay today. I'm sorry. Same time, 12:30. 12:30. Sorry for the delay today. I actually get something
No,
in the middle. I
no
stuck.
problem. Thank you.
Okay, thank you for understanding. And I get
Yeah,
stuck in the traffic. Okay, thank you.
man.
Sorry.
Thank
Okay,
you so
Thank you.
much.
thank you so much for
Thank you.
coming.
Tomorrow.
Okay, and Rahul, could you please do one thing for me? Create the pool on the group, like voting pool, the questions to be asked at the end of the lecture or in the middle of the lecture. Okay, so we will actually make a rule tomorrow, and the opinion is valid for the student because it wastes time, so we have to complete the task as well. Okay, all right,
All right.
so thank you so much for coming, and I see you guys tomorrow. Bye bye, take care.
Sir, I have a question, sir.
So what did you say?
I have a question, sir. If the patient have anemia, what are the changes in the preload and afterload, sir?
If the patient is what? Anemia?
Yeah, yes, sir.
Anemia, if the patient is anemia, what is going to happen to your preload and the afterload? The
Yes, sir.
afterload will decrease and the preload will decrease.
Both afterload, preload, both will be different.
Yeah, and you will tell me why tomorrow, okay?
Yeah, okay, sir.
Okay,
Thank you, sir.
go and search and tell me tomorrow. Okay?
Yeah, okay, sir.
Okay.
Thank you.
Thank you. Bye bye. Take care.